Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at ETSU's Bill Gatton College of Pharmacy. This podcast is sponsored by Kelly C. PharmD, an oncology education company for pharmacists. Today we have a new drug to talk about. Let's see if I can do better pronouncing this drug than I have in the past. Zidesamtinib. Zidesamtinib. Brand name is Jideytro. Jideytro. I don't know which is easier to say, to be honest with you. Like, the companies have a chance to make their brand name easy to say, and they choose to put letters together that don't typically go together in the English alphabet. Zidesamtinib. Okay, that's what we're going to say. Z-I-D-E. Zidesamtinib. All right. Whatever how you say this. I could do this for 15 minutes. So this drug, Zidesamtinib, is approved for non-small cell lung cancer, advanced non-small cell lung cancer. It's ROS1 mutated in a second-line setting. And not second-line after chemo, but second-line after a prior ROS1 inhibitor. We have a couple drugs already in this space. Repotrectinib and taletrectinib are probably the best drugs we have in the advanced ROS1 mutated lung cancer after progression on a ROS1 inhibitor. Lorlatinib has some activity. Most of the activity is in the setting of patients who receive crizotinib, which is maybe an outdated first-line treatment. And this data is 7 years old and has not garnered FDA approval either for whatever reason. Not sure if it was ever submitted. And then there's a little bit of data with entrectinib, but taletrectinib and repotrectinib are probably the other drugs this would be competing with. Repotrectinib in the second-line setting has an objective response rate of 38%. Taletrectinib has response rates of 52% and 62% in two different studies in this setting. So taletrectinib in the unfair cross-trial comparison looked to be more active. Taletrectinib also does not have any warning precaution statement about CNS dysfunction, which is pretty common. It is there for Zidesamtinib as well as repotrectinib. Taletrectinib has some QT prolongation. You can't date with antacids. Repotrectinib is a 3A4 inducer, so has some interaction with drugs like apixaban that would be worrisome. And Zidesamtinib is, kind of in between these as far as its side effect profile and apparent efficacy, which we'll get into. So this was just approved last week, right after I posted the podcast, basically. So the dosing here is 100 milligrams once a day with without food. Comes as 125 milligram tablets. You do need to do pre-treatment testing for CPK, because you do see CPK elevation, as with other drugs in this space, and myalgia. ECG, because there's a risk of QT prolongation. But also, you need a baseline lipase and amylase because of a fairly significant risk of pancreatitis. So you do have to monitor amylase and lipase while on this drug. So the CNS adverse reactions happen in a quarter of patients, which is, modest but present. There are other drugs like lorlatinib where that's a little bit more common. Cognitive impairment happened at 9%. QT prolongation, more than a 60 millisecond increase happened in 2%. For these patients in healthy patients, the increase in QTc was 13 milliseconds on average at its largest. ILD risk is low, as with pretty much every targeted drug in non-small cell lung cancer. Risk of skeletal fractures. Myalgia happened in 13% of patients taking this drug. Increased CPK just in 2%, so kind of a low risk. But this pancreatic toxicity happened, increased amylase in 22%, increased lipase in 25%. So you do a baseline and check it periodically. Certainly any kind of new abdominal pain, you'd want to check for that, since this drug does have that possibility. From the rest of the side effect profile, seems pretty modest. Edema and peripheral neuropathy, the most common that you see. About half the patients had an increase in cholesterol and triglycerides. A little bit of AST, LT elevation, but not enough to get a warning precaution statement. It's just a plain old 3A4 substrate. Not a lot of other drug interactions to worry about, except potentially with other drugs that prolong the QT interval, but it's not an inducer or inhibitor of any cytochrome P450 enzymes, at least as far as we know based on preclinical testing. Relatively new drug. As I should have stated to begin with, it's a ROS1 inhibitor. It does, as you would expect, since it's approved in the second-line setting after a prior ROS1 inhibitor, does have activity against some of the mutation that happens in ROS1 fusion gene products, including the G2032R mutation. Taletrectinib and repotrectinib also activity against this mutation, so you find that mutation, second line setting, either of these three drugs are going to work, or you kind of choosing between them, mostly probably based on side effect profile, drug interaction, and if you had your druthers, maybe you'd err towards taletrectinib with that numerically higher response rate. Metabolized hepatically, most of the drug is eliminated renally, no dose adjustment down to creatinine clearance of 30, at least as far as we know. How these new drugs are, say in about 100 people, they don't study them people with bad kidneys or bad livers, so what to do in the real world with those folks remains unknown. As far as the efficacy here, if you look at patients who received either chemo or a prior TKI, that response rate is 44%. If you just look at those who received a prior TKI, that's only 59 patients had received one. There's actually a study or a set of 58 patients who received two or more ROS1 TKIs, and that response rate was 38%. So this has reasonable response rate in the third line, third TKI. Having signs of activity, including some CNS evidence of CNS penetrance, with responses observed in 48% of people with CNS Mets at baseline without radiation in 2 months prior to receiving Zidesamtinib. Tough one to say. Maybe I'm losing a step here in my age. So this is a new drug approval. Very similar to what we see in this space. We have a single-arm study of about 100-ish, a little more than 100 people, and this is based on response rate. Duration responses are when the drug works, and it seems to work for a reasonable period of time. But is another option in this space. Is good to have, has some slightly different side effect profile than maybe, say, repotrectinib or taletrectinib, which looks to have a little bit less CNS impairment. Taletrectinib does. So, new drug to have, lots of new drugs to have. We're at this point now. Here's a challenge. Get out a piece of paper and see how many tyrosine kinase inhibitors you can write down. How many do you think there are out there? Gosh, we get so many new drugs. It is really hard to keep track of just knowing what drug is available and what's approved. And so, a lot of people listen to podcasts to try to keep up on this stuff. They're trying to learn oncology. You're new to the specialty, you're trying to deepen your understanding of a particular disease state, like not just lung cancer, ROS1 mutated lung cancer. Well, to help, Kelly Karlstrom, founder of Kelly C, PharmD, and ELO Collaborative, created the Learning Oncology Companion. It's a free template that provides a structured framework for learning any cancer type to help you organize key concepts like symptoms, risk factors, biomarkers, staging, and the treatment paradigm. You can download the Learning Oncology Companion using the link in the show notes. Okay, the last update I have is not necessarily new information, but it is the strongest information of something that we think we kind of know. So there is a lot of observational data, so like retrospective data, looking back at these folks getting immune checkpoint inhibitors in a variety of disease states and looking at, all right, so did they get PPI at 3 months, 1 month prior to starting their immune checkpoint, or they get antibiotics in 30 days, 60 days, 90 days before treatment. And, observational data, retrospective data is not great quality, but it has been consistently low quality in that being on a PPI or an antibiotic prior to an immune checkpoint inhibitor is associated with poor performance of the drug. Shorter PFS, shorter overall survival, and it's you can do, propensity scoring all you want. It's really hard in a retrospective way to tease out just sicker patients who aren't going to do as well anyway because they have poor ECOG, they have more comorbidities. They're sicker. That's why they're on PPIs. They're on antibiotics because, their disease is really advanced, say, in their lungs. So they have post-obstructive pneumonia, so they're on antibiotics a lot. It's hard to tease that out. Well, this was published in Lancet Oncology, and this is from the Pacific study. So this is the chemo, after you get chemo radiation for like stage 3B non-small cell lung cancer. It's not resectable, but We still try to cure these folks with concurrent chemoradiation and then the consolidation durvalumab. This is the Pacific study, and I actually have gone back as a post hoc analysis and looked at any time point before starting your durvalumab, were you on a PPI or an antibiotic? So it's just like one time, all right? And they find, so this is a randomized controlled study. Now, this was not the question that was asked, so they've gone back, they're doing some data dredging, but you do feel more confident when we know what drugs that these folks were on. And this also allows us to have, a comparison group of folks who did not get durvalumab, but also may have been on PPIs or antibiotics leading up to their randomization. And what we see here is as much as you can call this statistically significant in a post hoc analysis, this would have to be hypothesis generating for the purists in evidence-based medicine, but it's better than anything we have. And what we see here is folks exposed to PPIs, if they got durvalumab, the folks exposed to PPIs had a shorter median progression-free survival. And it's pretty sizable. The median PFS, if you had a PPI exposure prior to durvalumab, was 9.4 months compared to 17.2 in those without a PPI exposure before. Now, maybe they got PPIs later, but at least beforehand, they didn't. And that's a hazard ratio of 1.57. That's a pretty detrimental effect of PPI exposure pre-treatment. And that confidence interval is 1.28 to 1.93. So pretty decent impact factor. Now, those are folks on durvalumab. If you look at the same comparison of folks on placebo, the median PFS rates are 7.4 and 9.2. Hazard ratio of 1.02, not significant. If we look at overall survival for those folks in those who got PPIs and didn't, we see the same directional detriment. So median overall survival, 33 months if you were exposed to PPI before durvalumab, 58 months without exposure, hazard ratio 1.66. Again, a sizable apparent detrimental effect of PPI exposure prior to durvalumab. Now, you look at the folks in the placebo for overall survival. Median OS, 24 months, no PPI, versus 33 months if you had a PPI exposure. Hazard ratio of 0.78, so no apparent benefit. In fact, being on a PPI, was not hurtful. They did better. Okay, so what we see here is both for PFS and OS. If you're on the durvalumab group and you had a PPI, you did poor going into this. And of course, the theory behind this is that PPIs change the microbiome, which has a direct interaction with our immune system that can impair our immune system activity. Okay, so if you look at antibiotic use beforehand, we see a similar trend, although not as robust. So if you look at the folks on durvalumab, you see the median PFS in those who had antibiotics before treatment or not, and just any time they had an antibiotic, that median PFS for no antibiotics was 15.6 months compared to 9.2, hazard ratio 1.5, confidence interval 1.08 to 2.1. For overall survival, prior antibiotic exposure on durvalumab, no significant difference. 49 versus 38, numerically one's higher, but that was not significant. Confidence interval is 0.9 to 1.97. And then, of course, for those folks who were in the placebo group, not getting durvalumab, there was hazard ratio of 1.2 and 1.1 for PFS, OS. Both those confidence intervals cross 1 pretty wide. So, you're taking a PPI before durvalumab, you're probably on it long term. Even though PPIs are FDA approved primarily for like 8-week treatment for gastric ulcers, if you're on it for a long-term period of time, right? Whereas antibiotics you are only getting for usually a finite period of time. So this association, and this is the best data we have, certainly the best data we have for immune checkpoint inhibitors in lung cancer. I don't know of anyone else who has gone back and looked at randomized studies in other disease states. Maybe they have, and I've missed it. But this is the first one in lung cancer, which is the largest disease state where we're using immune checkpoint inhibitors. We use immune checkpoint inhibitors everybody with non-small cell lung cancer, so they have an EGFR or like ALK mutation, right? So pretty strong evidence. I think the practice before would have been, hey, we should not be using PPIs in people unless they need it. I think we need to start to become more vigilant about that. I was doing chemo education a couple months ago for a patient, and the first thing I do is a medication history, see what they're on, what they've been taking, that kind of stuff. What should they be taking? And this patient, of course, was on a PPI. It's like, well, what's this for? I don't know. They put me on that in the hospital, and I wanted to ask if I'm supposed to continue that because I only have one refill left, and I don't know if I'm supposed to take it. And so, I don't want to just say no. I don't want to assume the obvious, which is you were put on it inappropriately for stress ulcer prophylaxis when you didn't have an indication for stress ulcer prophylaxis by a hospital, and it was continued when you left inappropriately. I want to make sure, and that was, talk to the primary oncologist. That was the case. We need to do a better job as I think healthcare systems about reining in our PPI use, and would be a relative. It was pretty. I won't say it was easy. People going back 30 years have been talking so much about the risk of stress ulcers and prophylaxis. And I'll be honest, I'm not an ICU pharmacist, but I haven't seen a lot of stress ulcers in the last 10 to 15 years. So maybe we've overcorrected and we need to scale back how PPI-y we are on everybody. All right, that is what I have for you this week. Thank you so much for listening. You can follow me on X at FarmDeep and the podcast at OncoPharmPod at other social media platforms. And until I talk to you again, remember, doses matter.